conversation I'll have today is officially titled The Pain Interview, but unofficially titled Stop Trying to Cure Me and Start Listening. And I've borrowed this from a focus group of pain users that Eloise Carr, a nurse in England, when assembling a pain clinic and generating the usability by the patient group. The most salient and repeated conversation by patients with chronic pain is the quote I provide here, and therefore the pain interview, although an interview is a two-way street, part of that is going to be how to listen better. I too have no disclosures. I may offhand mention off-label use of medications, although that is not the focus of today's discussion. So very briefly, we're going to discuss in terms of what I hope you will be more capable of navigating is eliciting the biopsychosocial diagnosis associated with chronic pain, this importance of listening and perhaps how to do this better, to connect that the notion that the problem with chronic pain is the experience of the patient who's struggling with chronic pain, and that's way more complicated than the input into the nervous system from whatever external environmental danger or damage is actually coming in. Many of those signals are now internalized, and that's our focus in our interview is to identify them, and that the risk factors are often present in the story, and therefore the interview is extraordinarily important. And that validating this experience with your patient will facilitate your dialogue and your process of treatment engagement, and therefore very likely the success with your outcomes. So we're going to go back to the bio of the biomedical. We'll spend a few minutes on this, and this is the famous old carts. You can see I put A to the third because I felt that we needed to add attribution to the equation, and for some reason the AA wasn't mentioned, but the attribution of the experience, number 5, will at least tell us what the patient thinks it is, and if we're going to go to where the patient is, we need to hear what their attribution is and be able to describe in the language of the patient how that fits with our diagnosis. So onset, define whether it's acute or chronic. Location, critically important that we don't go brain dead. Thank you, Dr. Robbins, for that quote on our patients with chronic pain, because we often see chronic pain syndrome, which should be struck from all diagnostic lists, because that is as good as dropsy or consumption, in my view, because it doesn't tell us anything about modern diagnosis. So we need a locating diagnosis, a duration diagnosis, and to help us with that diagnosis would be the character of the pain, aching, squeezing, burning, etc. That will give us a sense of whether it's active nociception, active neuropathic injury, or a central, now sensitized patient. Radiation will help us determine whether axial pain, for instance, merits a evaluation for disc disease, if it radiates, or if not, whether it doesn't. The time of day during which your patient is having increased pain will also help us diagnostically in interpreting potentially causality such that at the end of the day symptoms are worse and we have a patient who's spending their day in physical labor versus at the end of the day the symptoms are worse when your patient is ruminating about how miserable their life is. It may certainly suggest a different attribution for the pain syndrome. And then associated symptoms, which we most certainly will want to pay attention to because many of those augment the severity and the suffering that our patients experience. So William Osler, nearly a century ago, reminds us how the diagnosis is important. It still is. And is something that we can often do a bit better job with our technologies. in terms of seeing stuff that Professor Osler couldn't see based on rudimentary imaging and less sophisticated laboratory analysis. But unfortunately, we become even more reliant on that technology rather than discoursing with our patients, and that chronic pain, in order to be understood, assessed, and treated, requires a thorough assessment of the social, psychological, environmental domains that will allow us to not only be more equipped to make the proper assessment and define proper treatment, but also to recognize environmental factors that we as the healthcare provider may be less equipped to be able to manage, and certainly not have us prescribing, for instance, high-dose opiates and benzodiazepines for environmental factors that we would not expect to be changed by heavy sedation and brain-numbing effects of our medications. So our current way of measuring pain is medieval, as this cartoon depicts. It's medieval not only in the rack and the garb and outfits of the treatment experts, I suppose, in the torture room, but also in the 0 to 10 pain scores that we use to measure particularly chronic pain. How pain should be measured, if we're moving through the diagnostic portion, and measurement allows us then to make an assessment, does include pain intensity, and I've given an asterisk by what's been recommended to proceed forward with clinical pharmacological trials. Fairly new, not so new anymore, but 8 years out, the recommendations that it be more than pain intensity, and the dearth of studies of any quality in terms of long-term opioid prescribing reflect the absence of measures of enjoyment or quality of life, interference with function, or impact on mood, which certainly are manifest and critical factors in our management of our patients with chronic pain. Interference with sleep is something that we here at the University of Washington, and I'm sure all of you who actually take care of patients directly, recognize that sleep disturbance is profound with our patients, not just as a risk, i.e. as sleep apnea, as a treatment risk, but in terms of pain intensity alone, can be increased 50% by poor sleep in basically acute volunteer experimental pain scenarios, but in our patients with chronic pain as well. And then the treatment risks relate certainly to behavioral risks that will have a negative impact on our expectations of patients' improvement, and addictions, which should help us better define those patients for whom we provide agents that are likely to aggravate addiction diagnoses. So kudos to Dr. Erin Krebs, a primary care internist, women's health specialist in Minnesota. She developed, published, and validated this 3-item PEG tool, as it goes, because it's pain, enjoyment of life, and general activity. That's what the PEG stands for. And this is validated to both the BPI and the Roland Morris. And we, therefore, have taken over 50 questions and give you 3 back on actual timed observations of my patients to fill this out. This is under 10 seconds and should be part of any and every visit that you see with your patients. With or without electronic health record, it'd be great to have this embedded in that record, but independent is something that is as important if you're managing pain as blood pressure, pulse, temperature, and respiratory rate. So this would be what I would recommend as perhaps a supplement or an alternative to the 5th vital sign. So when the patient reports and the pain intensity score, their pain is 12 over 10. The first thing, again, is what Dr. Robinson reminds us all the time, and Dr. Brett Stacy, our medical director upstairs, reminds our trainees all the time, is that nociception does matter, and patients with chronic pain without recent evidence of nociception still could have new nociception. So when pain shoots up out of the zone of the worst imaginable, even if your patient is typically 10 over 10, if it's only 12 over 10, it may be that there's a new acute injury or process that merits investigation. And this is a critically important component, and we have innumerable examples of patients, for instance, with chronic spine pain, multiple fusions, stable, who steps back in for a visit, perhaps an early visit, saying, my pain is out of control, it is 12/10, and it's different from me. And Tiffany Zhang, a PA who works with us, when she was seeing this patient on my behalf, identified a compression fracture above the apex of the fusion, did the appropriate workup, and he had multiple myeloma and was diagnosed at an extraordinary early time frame, and is now appears to be a sustained remission from his bone marrow transplant. And had this gone on and he became far more ill, I don't think he would have that great outcome. So pay attention. But even more importantly, and I credit an undergraduate journalism student in a course that I'm privileged to be able to work with very young but extremely open-minded and a diverse group. When I asked them this question, I think I gave it 20/10 to just highlight how it doesn't make any sense. And we had a number of pre-med people talking about drug seeking and the like, and he raised his hand sheepishly and he said, I think the patient may be shouting. Which was the most brilliant thing I have heard, because that's what we do. We raise our voice when we are not heard. And when we give someone a number scale, what they do is raise the voice of the number scale. And when a 12/10 presents, this means they are not heard, they are not succeeding in managing their pain. And as Wilbur Fordyce, back in the early 1970s, who was one of the founders of the UW Pain Clinic, this is a paraphrase, but identified that the pain intensity in a patient with chronic pain is about the capacity of the patient to manage their pain, and when they come seeking relief by coming to you as a healthcare provider, that language that they can communicate is in that number scale if that's all you give them, and it often has very little to do with stimulation of nociceptors. So this is why we ask you always, every interaction with your patients with pain, to evaluate mood. There's lots of different ways of doing it. In the far background is the PHQ-9. That's a depression score. Right in front of it is the GAD-7. That's a validated anxiety tool. You take the top two of each, and that's the PHQ-4. And you can see nervous, worrying, feeling down, depressed, hopeless, little interest and pleasure. You recognize those from those two scores. This is a 4-question item that's validated to trigger a more advanced screening instrument that will allow you to get more granular and often pick up a great deal more depth. Many people say, well, how about the PHQ-2? Well, the PHQ is just 2 questions off the 9. It does not reflect anxiety, which, though, doesn't represent at the 50 to 60% of patients with chronic pain, is in the 40 to 50% a range of patients, the anxiety that needs to be managed, and it's therefore no surprise that when these pain scores go up, our patients are treated with benzodiazepines, hearing that as anxiety, when in fact that is not an evidence-based treatment for management of anxiety. When these scores are elevated, I would recommend, and in my own practice, introduce the PTSD screening tool, which in this clinic, a quick survey showed that in about 35% of our patients scored positive for PTSD. Now, no question, we see folks who have failed many other therapies before they get here, but undoubtedly this is an unrecognized component of our diagnoses and therefore must be taken seriously. Referent to the PTSD questionnaire, this is Bob Anda's adverse childhood events sequence. If you haven't seen this before, I think it's extraordinarily important to call this out for you, and those who have, let me just reinforce its value. These are essentially, and I'm nervous because I have a true expert here in the room, 2 true experts about whether this is really a PTSD setup, any of these symptoms, but I think they are these exposures: abuse, sexual abuse, alcoholism in the family, disrupted household such that a family member is in jail, severe depression, hospitalization for mental illness, suicidality in a family, watching your mom be beaten, emotional, physical neglect lead to a robust correlation on the right. What we know as poor health behaviors that lead to a variety of complicated social and hence environmental complications. And I've taken the liberty here, this is not on Dr. Anda's score, but adding chronic pain, because this is what we see in this clinic on a regular basis and not to be missed, and it is not going to be uncovered except in a 12/10 pain score that leads us to push our patient away. So I language this directly with my patient to get engagement. I see these high scores. I don't want to say it's all in their head. I don't want to tell my patients that it's PTSD or anxiety or depression, because that suggests it's a psychological or psychiatric condition, when in fact it is experienced as a biological, a sensory phenomenon. And by using the language which I've selected, because functional MRIs use the fire colors when they make it easier for us to interpret what's very active or not active. But the brain's on fire, and I use that repeatedly in my evaluation with patients, and I have not had a single patient respond, "No, doc, it's not in my head." And what I hear instead, and I just heard this on Tuesday, the last patient of the day, "I think your brain's on fire," and I repeatedly get, "That's exactly how I feel." And that's exactly what we want patients to say with our initial interview, because we understand them. And I asked that woman when she left, and she had 10/10 pain when she came in. And on the way out the door, informally, I said, "So the 10/10 when you came in, how do you feel now?" And she says, "Oh, I'm about a 5/10. And I said, "Why is that?" And she said, "Because you understand what I'm going through and how I feel." And a 50% reduction in pain intensity without providing an IV fentanyl dose has never been reported in the literature in even acute or chronic pain. So these are interview skills that I hope you might be able to incorporate. Many of our fellows have and have felt the same feedback that it's one way of communicating this. Your patients go on a journey. They don't start isolated, angry. They present to us angry and isolated, but it begins with ineffective treatment. So over-promising, "Oh, we'll do this back surgery and your pain will go away." Or you're going to go to the hospital for a surgical procedure and don't worry, you won't have any pain. That's a setup for an effective treatment. So you need to set the expectations correct, because a series of unmet expectations delivered by a provider for whom they feel is a close caregiver and is supposed to take good care of them, and it is not met, and instead they come out worse and feel harmed by that. That sounds like childhood sexual abuse to me. And it's no wonder that patients with multiple spine surgeries score positive on PTSD scores. Patients who've been in the intensive care unit for more than 3 days will score positive on a PTSD screen. Again, PTSD will lead us to this. A overwhelming threat to one's integrity is how Dr. Carrie Stevens, she does a didactic with us, is her simplest definition. An overwhelming threat to one's integrity. It sounds a lot like pain that has ruined your life. And the 0 to 10 score for the Department of Defense, they anchor it in language. The Department of Defense score says 10/10. Nothing else matters. And when nothing else matters other than your pain, it's very, very difficult to fill that suffering space with drugs or pats on the back or more examinations. It requires meaning and purpose being introduced back in individual's life. Unfortunately, we are still overly reliant on opioids. I'm happy to report that those of you in Washington State can look around and say, congratulations, we've done a great job. We're the only sustained state that has been able to reduce its opioid accidental overdose rate by 40% down over the past 6 years. The doses of opiate prescriptions are also down in Washington State. So our death rate's down, our MED's down. This is not happening nationally at this point. There's a few other folks who flatten the curve, but we are now taking the lead on reducing the deaths, and I know heroin addiction is up, but the heroin addiction curve does not map to the opioid dose reduction curve. It seems like an epiphenomenon, perhaps, but it is an independent, overlapping event. But reducing opioids will not drive your patients to heroin unless they have addiction. So we want to assess that early. We only have to do this once. You can see it's a family history, personal history, high-risk age groups, pre-adolescent sexual abuse, that's a PTSD surrogate, and psychological disease. I talked to Lynn Webster just last week. He was at the national meetings, and I said, Lynn, why did you only give 0 to men and 3 points for women? And he said that he was sticking to the evidence of PTSD following pre-adolescent sexual abuse, and he said there were no studies on it. So he put a 0 in. It is absolutely a critical question to ask men as well. And in my experience, since I've been using this, with one exception, every other man who's had chronic unexplained prostate, testicular pain, or any genital locating pain has had an experience of perception of a threat to their sexual identity, and often it's a gender identity concern as well. So you can score it as you wish, but high scores indicate not addiction, but they're going to get into trouble. Mike Von Korf told me recently, this is interesting data, 1 out of 9, I got the numbers wrong, 1 out of 7 patients don't get into trouble on long-term opioids. That means 15% of your patients are going to do fine. That's good. We want to find out who they are, but they're not going to be in the group that are high risk for opiate misuse. So we want to make that selection carefully. We want to avoid that 85% group that long-term opiates, particularly escalating dose, are going to produce a problem. So what do our patients expect, and how often do they catastrophize? Well, it's a terrible problem, catastrophizing. If I do this, then that will happen. Catastrophizing isn't unique to pain, but it's certainly unique to patients it's a significant factor in patients who experience pain and experience a sequence of unmet expectations. Kinesiophobia, great term, makes me sound smarter than I am when I can use a polysyllabic word like that. But it basically means movement is scary to me because when I move, it hurts. Dr. Robinson will bless us with his way to help us navigate introduction of physical activation through physical therapy, but alerting your physical therapist to the fact that your patient is kinesiophobic and therefore they're not to be given a athletic performer who has a rotator cuff from a football injury. They are not treated the same way patients with chronic pain are. Hopelessness, isolation, high prevalence of PTSD, these again factor into the psychological considerations. And therefore, it's critically important that we set the expectations that a chronic illness, by definition, is chronic. It will not be cured. It will only be managed. It will be managed poorly or it will be managed well. And your job, I hope, as you would see it, is to assist your patient in the self-management tools with whatever medications, perhaps surgeries, procedural interventions that will allow them to begin to introduce self-management techniques into their program, locate meaning and purpose in their life. I wish I had a prescription that would be filled at the local pharmacy. Find meaning and purpose in your life. I have written that down a few times to those patients who are able to accept that. I can't do it in Epic anymore. They don't give me a free text code for a prescription for meaning and purpose. Maybe we should add that, navigate that, a prescription for that. But we can offer that in many respects. And the other expectation setter is the patient care agreement. It's not a contract, but it just very simply, it sets our expectations for the patient. And therefore, in our conversation, we should explain it as such. We'll have more on that later. Dr. Merrill will be delivering a motivational pain interview, didactic as well. Simply put, in the interview, establishing that the status quo is unacceptable for your patient, and we'll go through that in some of the cases today. Getting the patient to recognize that what they're doing now simply ain't working, that change is possible, that change can happen, and that change, therefore, can continue. And as the patient evolves from readiness to change, to beginning change, to making change, the kinds of coaching and other techniques. And we do this, we do listening and coaching really as a dance, in that we have to follow. If it's scripted, sometimes the visit goes as you expect. Doesn't happen often enough for me, I think. But when it goes as you expect, you can follow the dance steps. But even then you have to follow your cues that your patient's providing. But often it's a jazz dance where we need to improvise as the patient moves forward. And therefore, that requires listening to what they're saying so we know what to improvise on. So the listening experience is as a witness. Let him tell the story, and then you can advocate and validate. And then entering the patient's viewpoint allows them. This is exactly how I feel, is one, as I urged before, explain to the patient that I know what they're going through and my ability now to get success with engagement in my treatment recommendations and the likelihood that my effective drugs will work even greater. Don't forget, placebo effect accounts for 40% of the treatment that we use. And that's a sign of how powerful the brain and our ability to work with our own brain and believe that there's hope and purpose that we can actually self-engage can allow our patients to move forward. So quick summary: listen, empathize, validate, advocate, support. All this is built into the basic skill set that led you, desire to do this, led you into primary care roles. And in that role, 6 tools to use. We'll have a separate session on how to use the morphine equivalent dose calculator. But if your patient's receiving opioids, you're going to want to know what that dose is, so then you can manage it.